Hello, everyone. Welcome. I'm Angela Love Zarenka with Lactation Education Resources, and we have the great honor and privilege to host Nikki and Nikki today. And the topic is What's the Big Fat Deal, with their very special guest. So I'll turn it over to them to let them introduce her.
Hey y'all, welcome back.
Hey, we here.
Hey, we're here. We're here. All right, by way of introduction, I am Nikisha Killings, private practice IBCLC and equity strategist. I am also the director of equity, inclusion, and belonging at Lactation Education Resources, who we are honored to have host us here today. I'm joined by my co-founder, Nikki Hunter Greenway.
Hey everyone, what's up? I am Nikki Hunter Greenaway, also known as Nurse Nikki. I am a board certified family nurse practitioner and an IBCLC in private practice in New Orleans, Louisiana. And I'm happy to have y'all here. We are towards the end of the year, guys, and we want to end on a bang. So we have a great guest today, and we'll allow her to introduce herself.
Yes, who are you?
Hello. Hi, guys.
Hi there.
I'm so happy to see your happy, smiling faces today.
Yay.
I am Kristin Cavuto, Kristin Cavuto, also known as, I suppose. And I am a LCSW and IBCLC in private practice in New Jersey. And I am here to talk about fat phobia and anti-fat bias. Is there anything else you guys want to know about me or what I do?
Yes, in a second, we will ask you how you're doing, but we'll give you a minute to think through that because sometimes it takes a minute these days.
Right.
So I mentioned Nikki was my co-founder. She is my co-founder in Nikki and Nikki Lactation Career Consultants. I should have said that. So together we work on helping people to prepare to sit for the IBCLC exam. Had to get that out the way. So how are we doing today? Well, I'm still in Florida. In
Yeah.
case y'all are wondering.
Yeah.
That answers itself.
Florida man.
Mhm.
It does. But I think I am in a better place than I was 2 weeks ago. We last saw you all right after the morning after the election. So I'm in a better place. Still tentative, still, waiting for some shoes to drop and some things to catch fire. But here, still doing the work, still present, still taking care of families. I'm really grateful for that. And my family is continuing to you know, deal with this new normal and everyone is well.
Mm.
So I'm thankful for that. How are you all?
You can go ahead, Kristen.
I'm anxious, have insomnia. Uh, I think a lot of the same things that a lot of everyone else is going through. All of the normal coping mechanisms aren't working as well, and all of the destructive or self-sabotaging behaviors are up rather than down. And I feel
Yeah.
like, it's funny, people say, well, you're a therapist, you should be able to handle all this. And I'm like, sweetie, people get into therapy because they have problems. Like, you become a therapist because you need therapy, and that's how that works. So, therapists are the group most likely to need a lot of support in hard times in my experience. So yeah, it's been rough, but like Nikki said, I have hope that things will be peaceful in the transition over the next few months. I don't expect it, but I hope for it. And I think that's the best I can be with that right now. I will say, if I'm going to be completely open, honest, and vulnerable here, that this topic makes me feel vulnerable. It makes my heart feel tender. So I hope everyone will be gentle with me because I am feeling a little delicate about it.
Thank you for sharing that. We got you.
Yeah, of course. Of
Yeah.
course. I'm in New Orleans. And I think since last week, like the anxiety kind of waned from the election. And I know some people are still high off of that, but I'm gonna be honest with y'all, I got to do. Like I still have patients and the number of patients haven't decreased. Like the work still continues. And I think that's a big thing. Like after this, like a lot of us, are anxious about it. But I was like, in my anxiety, I can't just sit because then my patients pile up and their issues still get bigger and services still need to be rendered. So I have a lot of patients. I've been in doula mode for the past 24 hours. which I don't tend to step into at all. I don't want to mess it up for all the doulas because I talk too much when I get to the hospital. But yeah, I'm okay. I'm all right. It's a day by day thing, type of thing, a situation by situation. As we, ponder, we're back to this issue of, are we going to shut down again? Which states are going to shut down? Because actually, if you shut down some states and not others, that makes sense, actually. But especially if you're allowed to cross borders, which is what we're experiencing here in Louisiana. When the shutdown happened, we were number one, right, next to New York, because we had just had Mardi Gras, and so we took a slower approach than everyone else. And now our numbers are actually pretty good compared to everyone else. We have some of the lowest, and now folks are like, "Oh, I'm gonna go on my honeymoon in New Orleans." Oh, and so our numbers are starting to go up, and I'm like, did y'all not remember Mardi Gras? Did you not remember? So that's where we are right now. It's just we're still cautious and aware and things like that. So yeah.
Welcome, guests. Thank you for being with us. Let us know how you are in the comments. Angela will send those over to us. Someone from Los Angeles, or is it Louisiana? I don't know. Someone from LA, she says, is super excited about this issue, and I don't know where they are, which of those they're in.
Los Angeles, sorry.
Los Angeles. Yeah. This is a big topic, and I'm so happy that we have the opportunity to address it in this particular forum. We'll give you a little bit of history, or we'll say at least that I think this is a space where lots of folks get it wrong, and there's a lot of opportunity to grow and learn about this particular area of bias that I think is not, the light is not shined upon it enough. And even those of us at LER who do, we work really diligently to make sure that we're speaking to all audiences and that we are very careful and honoring and respecting all of our listeners. We sometimes, mess it up. Or sometimes we make reference to things that are, dated. And Kristin caught us on one, a reference that we made someplace regarding fat and fatness and obesity and what that has to do with lactation. And so we wanted to have her on to set us straight and set us all straight in terms of what is true and how we can all be better in this area. Right? So thank you for being with us today. Thank you.
Yay. I'm really, really happy to be here. Thank you so much for having me. Oh, Nikki, I can't hear you.
How about that?
Yes.
Yep.
Yeah, sorry. I bumped the mute button on my headset. Those who have been with us before know that our conversations flow pretty organically, but we have just a few guiding questions to make sure we stay on track. So my first question, I think, would be, what is fat bias? What are we talking about here? What is it and how does it manifest? Kristin, you want to take that?
Sure. I mean, this is sort of a huge topic, just like any other form of bias with like racism, sexism, homophobia, transphobia. We're dealing with it's not just one issue, it's intersectional and it's huge. So we're going to break it down a little bit into the different ways that fat bias manifests. And obviously I want to focus on healthcare because that's where we all are. But the first thing we need to do is talk about some facts and just some way things are. So for a long time in this country, we've had a literal sort of like war on obesity, they call it. And it was like literally declared, and it's very much like the war on drugs. It's actually caused a lot more harm than good to the people that it claimed to want to help. And there's a lot of ways that happens. What it really did was go along with what a lot of people already think, that fat is a moral failing rather than a physical difference, a physical, part of the beautiful diversity of human beings is, body shape and size. So when people think of fat, especially in our culture, in Western culture right now, they think of lazy, slovenly, they think of lower ability. In fact, they think of people being less trusted, lack of self-discipline, less intelligent. And I don't know if you guys know about the Harvard implicit bias tests. That they test people for what your sort of subconscious biases are, so that there's tests for everything. There's tests for sexism, for racism, for colorism, which is super interesting. And there's one for fat people. And it comes up over and over again that people think of fat people as being morally deficient. And that's something that comes into play everywhere, including in healthcare. So we have, a lot of sort of pain around fat and a lot of struggle around fat, and there's some reasons for that. And the main reason is capitalism, which of course is one of the reasons why everything else is too.
Yeah.
Here's some interesting facts. So the commercial diet industry is worth $72 billion. More than a quarter of studies on obesity and health have authors with a conflict of interest in the diet industry.
Wow.
Yeah. Bariatric surgery is covered by insurance and pays extremely well. So that's one of the things going on. And as of just about 10 years ago, doctors can now bill specifically for counseling on obesity at every session.
Oh.
And because it's considered a disease in and of itself right now, even in the absence of any disease process, it's considered a disease. And so that's an extra code to bill for. So harassing fat people is considered a code. So if you come in with the classic example is you come in with a broken leg and you say, ow, and the doctor says, have you thought about losing weight? So that's a really sort of classic example with that. But yeah, the why is almost always, trying to keep people in a position that just, keeps them down and takes their money from them. So that's a lot of the reason of why. So do you guys have questions about like some of the health facts? Because I know that's one of the questions that someone sent us is, the concern about, I call it concern trolling, but a lot of people are very concerned about their fat loved ones and their fat clients and saying, well, aren't they unhealthy?
Yeah, I think we'll get into that a bit. I want to pause though on something, a few things you've said. This sounds a lot like, I've been doing some research on the history of the formula industry and alternative baby milks for a lecture for LER coming up. And this sounds a lot like that industry in terms of who's invested in it, who profits from it, who controls the language around it, and how families are even counseled, or what recommendations they receive. This is fascinating that there are so many similarities around this, and I'm concerned.
Well, what's
quite
interesting is
frankly.
that they even popped up around the same time in our history. So before the 1920s, people didn't worry too much about doctors and healthcare people didn't worry too much about people's body size. They looked at their health. They looked at, are they able to do their work? Are they able to get around? Are they able to do the things they need to do? But in the 1920s, life insurance companies started using a weight chart as a metric of insurability. So it started with the life insurance companies. And right in the early part of the 20th century, which is the same time we started seeing that baby food industry and that formula industry. So what's interesting is that then after the life insurance companies started using it, then the doctors started adopting those charts in absence of any medical data to their accuracy.
Yeah.
And so here's the interesting part. Those are based on like this concept of BMI. And I know you guys probably know this, but BMI was, so those life insurance charts and BMI were based on European white men. And they were looked at, basically they said, well, who lives the longest? And let's look at their weights. And those weights should be the healthiest weights. Well, they weren't also considering that those were the people with the most privilege in every aspect of their lives. So of course they lived longer. These were
This
people who
sounds
had
a lot like the growth charts, the baby growth charts that we used for so long and
so
tried to get folks to throw out.
Yeah, so those life insurance charts were based on people who, of course, were going to live longer. They had access to, they had money, they had access to healthy food. They weren't working in factories, 18 hours a day. So of course they weren't subject to the weathering of racism every single day. So of course these people were healthier. And so we looked at their weights and basically started judging everybody based on those weights and honestly finding them lacking, which is why BMI in and of itself is essentially and deliberately racist. It's essentially and deliberately sexist. And so those things are really important for us to remember. And it's also essentially and deliberately classist. They weren't looking at working class or poor people. They were looking at middle class and well-off white European men specifically.
Yeah, wow. That's a lot. That's a
It
lot, Kristin. Hang on.
take a minute with that one.
It's a wild ride here, folks. Whoa, okay. So I get this. I get this kind of really at a really deep level, as I'm sure the audience does, in that I'm one of, many folks who, started to track my weight, I guess, in middle school, right? Which is, to me, mind blowing now that I have a middle schooler. I cannot fathom her all of a sudden being concerned about her weight, but I was. And I was so based on some chart I saw someplace that told me based on my height, I should be this certain weight. And I was already outpacing that, right? At 12, at 13. And so I can see now how insidious this is and how much it impacts us, at a really early age. Now, granted, not all bad, right? There are some causation, not just correlation, but some causation points regarding weight and healthiness, right? To some
But what's
degree. Are you telling
interesting
me
is
none of that is true?
what I'm telling you is that the research actually shows us that there is correlation, but there is not causation, and I can talk a little bit more about that. So
Interesting.
there are obviously people who have, metabolic profiles that are unhealthy, right? People with high blood pressure, people with high blood sugars, people with insulin resistance, all of those things are true, right? And we associate those things with fatness. And there is a correlation with fatness, but here's the interesting part. So fat people with healthy metabolic profiles, so fat people who just happen to be fat, who do not have high blood pressure, high blood sugar, insulin resistance, metabolic syndrome, any of those things, are not more likely to become ill or die than thin people with a healthy metabolic profile. So fat in and of itself is not correlated with death or disease. Okay, so for people with unhealthy metabolic profiles, this is actually interesting. So for all people who may have an unhealthy metabolic profile, fat people, thin people, average sized people, fat people are actually less likely to get sick or die than those who are even slightly underweight. So it's healthier to be overweight or obese than it is to be even slightly underweight. And that's something that we certainly don't talk about in our culture. And
No,
what's
not at all.
interesting, in
But we're in
all
a culture of excess, though, right? We're in a culture where people generally, are have an abundance of options of where to get food from. Obviously, not everyone is food safe, food secure. Absolutely not. That's not the point I'm making, or even have access to healthy food. But I think there's some interesting, kind of delineations you can draw there between what people have access to and what is considered good decision making, I think.
well,
Don't let me
absolutely.
get us on a tangent. Go ahead.
And again, we talk about decision making about food as if it's not completely controlled by a capitalistic market and our ability to access food, as you pointed out. I mean, and honestly, what I think is very deliberate, refusal of access to healthy food to poor people and people of color. So, I think it's made this way. I think it's this way on purpose. But the point being is that if you're looking at all of those BMI categories, even though we know BMI, the healthiest category, if you're looking at correlation, is actually the overweight category. So
Do tell.
so there's underweight, there's what they call normal weight, there's overweight, and then there's obese, and there's like 3 categories of obese, just to like make you feel super special when you can be like, I got obese 3, I'm so cool. The category that is associated with the least risk of illness and death is actually the overweight category. And what's interesting is, of course, those categories are arbitrary. They mean nothing in reality. They were set up by a bunch of people who aren't supposed to be looking at individuals, they're looking at populations. And what actually is interesting is that let me get the year for you, in 1998, and you guys might be old enough to remember this, I remember this, they adjusted the BMI, and suddenly a whole new group of people were, overnight, they became overweight.
I remember that.
Yeah. So it's arbitrary and doesn't make a whole lot of sense. But that group that now is considered overweight actually has the best outcomes of any other group. So what I also want to talk about is this. In people who are fat who have metabolic disease, so those are 2 things. So fatness does not equal metabolic disease. And that comes into play with lactation a lot. That comes into play with perinatal care a lot. We can talk about that. But in fat people with metabolic disease, so fat people who have high blood pressure, who have diabetes, have something else going on, fat is often a symptom of the disease rather than the cause of the disease.
Yeah, I was going to ask you about that chicken and egg thing, right? What came first?
Well, what seems to come first is the metabolic problem. And so we have people, in puberty developing metabolic problems and not being diagnosed, developing hypothyroidism, developing insulin resistance early. So you can, if you're looking carefully, you can see symptoms of that. And you're not going to see increased blood sugar in a 12-year-old usually. I mean, in extreme cases, sure. But most of the time, you'll start seeing the little things. You'll start seeing the skin tags. You'll start seeing the extra dark patches of skin on the neck or under the arms or between the legs. Those are all, or they get real hangry, real pissed off when they're hungry. Those are all signs of insulin resistance. And that can start early. That can start in childhood. And it's usually not noticed and it's not treated. And especially for people who don't have access to healthy food, it continues. But just, even if that person is not overweight, those symptoms of insulin resistance cause fatness to accumulate. So fatness is often a symptom of the disease that started first.
Understood.
So there is that correlation, but it tends to go in that direction. And of course,
not
we
always,
blame,
but often. Yeah.
yeah, we love to blame people for their diseases in this country. We love to make people's fault when they have disease of any kind. You know, we tell people with cancer that they had negative thinking. You know, I mean, it's ridiculous. So of course, we love to tell fat people who do happen to be also unhealthy. You know, so we need to separate those things. Fat does not equal unhealthy, just like thin does not equal healthy, right? Like you can be thin and be dying.
So yeah, I got thoughts. Nikki, if you got thoughts, jump in, please.
Yeah.
And we have questions from the audience as well. You want me to jump to the questions, or you want to say
Yeah,
something?
go ahead and jump to the question.
All right. So first, I want to. We have a listener from Indiana whose heart is also tender right now. I want you to know that we are with you, and you are not alone. We're holding you as well in this moment. First comment someone says was, when creating those original charts, there was an assumption that weight and longevity had a positive correlation. I think that's kind of what you were sharing with us, right? Yeah. And then someone says, I was taught that obesity is a dysfunction of the endocrine system and therefore is a high risk for delayed and impaired milk production. Is there actually any evidence of this? As an IBCLC, I have not noticed this to be true. I know the listeners here are either actively in lactation support or on their way, they're students. So everyone wants to know, how does this show up in lactation? You know,
Sure.
Does it in fact impede lactation? Talk to us, Kristin. What do you know?
Sure. So let's talk about this. So we know that an unhealthy metabolic profile can impact lactation. Period. End of discussion. That we know that. So we know someone who has insulin resistance may have low milk supply. Okay. We know that in fact, we know that insulin resistance during puberty is a leading cause of IGT. Absolutely a thing. We know that people who have metabolic disorders have a delayed lactogenesis too. We know that, you know, it tends to take longer for the milk to come in and lots of stuff tends to happen that can snowball into failed lactation. So we know this. And then we have that correlation where in many people, but not all, and this is important to remember because you can be walking around with thin insulin resistance all day long, and I see it all the time, and people aren't being diagnosed who are thin because no one thinks they have insulin resistance because they're thin. So, but in people who have insulin resistance and who are also fat, they absolutely can have those issues and those things can correlate. Okay, so it's not the fatness in it of itself, it's the metabolic disorder that's causing issues with lactation. And that was my issue with the study question, was that the research just calls it, well, obesity is the reason. Well, the research is biased. I mean, we know research can be biased all day long. So the research is saying, well, we see this group of people that we're studying and we see that they're having these lactation issues. Okay, so we're observing that they have lactation issues, and we're also observing that they are what we like to call obese. I just generally say fat because it's in my mind, that's a lot nicer than using a medical term for someone. You know, fat's just a descriptor like blonde, you know, it doesn't mean anything really.
I want to get into the language a little bit later too, because I think there's probably not consistency on that.
So we see these people who happen to be fat and also happen to have lactation problems, and we make this correlation when really we're looking at people who have metabolic disease and have lactation problems. Okay, and what we are doing in that is we are putting a stigma on fat people, and we're missing a whole group of thin people with metabolic disease who need treatment in the same way that those fat people with metabolic disease need treatment. I actually, because I specialize in low supply, I see a ton of people all the time who have flaming insulin resistance, but because they are quote unquote normal weight, no one has even discussed this with them. But I take the history, find out they have a family history of type 2 diabetes, 3 generations back. Grandma lost her leg and grandpa was blind. And they have every symptom of insulin resistance. They've had it their whole lives. No one noticed because they were always average weight. So we see that a lot.
Yeah. Okay, we got more questions. I feel like so many of them are related, but I'm going to rail them off anyway in case you have a new point you want to speak to. And Nikki, please
Sure.
jump in. I will say though that in my experience supporting families, I've not seen more issues with lactating or hitting lactogenesis 2 in obese people or fat people. I've not seen it skew heavily depending upon weight. And that's, anecdotal, but to your point, that's going to be the experience of a lot of us now that we have this, working knowledge. All right. So the next question was, yeah.
I would say I would agree. I haven't seen, and I agree that, metabolic disorders cover all different weights. As someone myself that is insulin resistant and has been since I was 16. But I do think as a provider, it is important to capture weight during a visit and to see because I feel like, especially during perinatal times of you pregnant and some of the complications that can happen, or so things to be aware of in the back of your mind. It's like, okay, this could happen, but obviously it could happen with all. But I feel like when you have extra adipose tissue, especially if you need a C-section or you have had prior surgeries or things like that, I feel like that it's an important thing to capture. Now with the BMI, yes, it comes from the origin of it, and it does need to be the way in which we capture it should be revised. But I do think it is a good metric to capture, just like we capture blood pressure. Then people have high blood pressure, just like anyone with a higher BMI. So those things, obviously, they can have some biases in them, but the number itself, I think it's worth capturing.
Yeah, and Nikki is, if I can say, you're speaking from the perspective of someone who does more than IBCLC work, more than lactation
Oh
work.
yeah,
Like I
yeah,
don't
exactly.
necessarily have reason to weigh my clients.
Oh
But
no,
Nikki
I
most
wouldn't.
certainly
I
does.
mean, if
Yeah,
it's a lactation visit, no, but I'm doing like
yeah.
postpartum visits, and to me,
Yes.
that's important.
You're
Well,
following trajectories, making sure people are on healthy curves. Yeah.
and
Right.
so what's interesting about that is that, like, for instance, during pregnancy, taking weights is important because you could be looking for things like preeclampsia, right? So
Right.
that's a thing that's a legitimate use of weight as a medical indicator. The problem is that we are so focused on weight and obesity and fatness as disease process rather than just a facet of human life that is sometimes correlated with disease, but is sometimes not, that we tend to look at it, outside of context
Yeah.
and in a way that ends up being oversized, outsized.
I understand. It
Some,
becomes the issue. It becomes the main issue as opposed
especially when
to
you're
a
allowed to bill
person that
for
is
it,
pregnant.
and the other thing to remember is that everything we do is a risk benefit analysis, right? So remember, weighing somebody is an intervention. Okay, it's an intervention just like anything else, and so we need to decide if that's a risk benefit analysis. There may be, it may be 80% of clients in which that is a neutral aspect for them. They do not, getting a weight check is not a big deal, and so it may be a benefit to take that. There is a distinct group of people, maybe even 20-30% of people, especially women in the childbearing years, who it is not a neutral thing to weigh them, and you need to discuss that until you can get informed consent, just like you would with any other intervention. And we don't think about that. We think of taking weight and blood pressure and some of those basic things as just part of our assessment. We don't consider it as an intervention, but it has the possibility to cause harm, and it has the possibility to, just seeing those numbers. So there's some interesting statistics about healthcare and discrimination. And so seeing those numbers can cause that bias to come forward in even the most open-minded provider's mind. And it can bring up, if a client does have eating disorder issues, it can be a real trigger for that. More than 24% of nurses admit that they are repulsed by their fat clients. That's a quarter of nurses say that they are repulsed by the bodies of some of their clients. More than half of physicians say that they think fat patients are non-compliant with treatment, in any treatment, not just treatment for obesity. 80, despite all the evidence to the contrary that dieting does not work, 85% of physicians, they say that they counsel clients to lose weight at every visit, regardless of the evidence. it's really bad. I mean, there's people, so it is an intervention. So that's all I'm saying is we have to be thoughtful about it, just like we thoughtful about everything else we do. You know, I know, like, if I'm with someone lactation, sometimes I would like to do a breast exam. I would like to see both breasts out naked so I could really get a good look, especially when I'm looking for IGT or something like that. But I need to think to myself, getting this person fully topless in my office, that's an intervention. And for some people that will be neutral and they don't care and they take off their shirt and they're perfectly happy to be half naked in my office. And for some people that's going to be possibly damaging, and I need to feel that out before I decide if it's worth it for me.
Absolutely. Yeah.
So yeah.
I think, I mean, obviously with consent and then talking about how the exam is going to go and how they feel about each part, that's
Yes.
for anybody.
Yeah.
That I do that, you know. So I totally understand that.
I do
All right.
recommend weighing people backwards on the scale so that they can't necessarily see the number. And if they ask you why, you just say, because I'll tell you, you know, if I'm worried, I'll let you know. But especially during pregnancy, some people really freak out about every pound postpartum. So that's an option. An option is to weigh people backwards. And I know that, you know, I refuse weight checks at a lot of doctor's visits, but when I do them, like for an annual visit, I feel like it's fair for them to get it once a year. And I ask them to weigh me backwards and not tell me the number unless it's something dramatic. So that's an option we have as providers.
So we got questions. We got tons, and I don't even know, and they're all over the place.
Okay.
So we'll try and maybe answer them succinctly so we can get them all in. All right. So someone on the call is a CLC, and they were told that obesity can cause delayed L2, right? They're asking, is there a bias about latching babies onto larger breasts, and can we speak to this? Absolutely. Absolutely.
Yeah.
I got a call this week for an image of, there's a really now becoming famous image that Tana Kamara took of one of her patients. There's, you know, there's a huge breast, it's a larger person, but a huge breast, and she crafted a sling from a blanket in the hospital. And I'm getting lots of demand for that image. Like, can you send that to me? Can I get that? Because now it's, you know, a hot topic to talk about. Propping up, you know, the breast and
Propping the breast.
helping babies get latched onto these larger breasts. I don't know why this wasn't always being talked about, because they were always
Right.
large breasts, but okay, here we are. So
Right.
is there a bias among our fellow practitioners dealing with breasts that are super large or people that are larger? Yeah, I think so. What have your experiences been?
Yeah, 100%. I mean, there's a ton of anti-fat bias in perinatal care. Often fat parents are just told that they can't breastfeed or that they're given formula much more in the hospital. I mean, and again, this is intersectional, and we always need to remember this. Like, we know that Black women are offered formula, 9 times more often than white women in the hospital. Well, how do you think it is for fat Black women? You know, it's possibly double that, right? So there's always that intersectional and that additive quality of any kind of oppression. And yeah, absolutely. Fat people are often pressured to be sterilized during birth, just like other oppressed groups. 15% of OB practices don't accept fat people at all. They just say, no, thank you. We won't take your business. 15% of American OB practices. Yeah. So that's something to think about. And fat people have a huge rate of unnecessary intervention. 71% of people who are categorized as obese have C-sections, despite the evidence being shown that only very few fat people need them at higher rates than thin people, right? So, and the same thing goes for, you know, for breastfeeding issues. Like, they have double the rate of induction, and it's usually because of provider attitude, not because of any, you know, physical indication. So it's basically people just seeing fat and assuming disease. And that assumption of disease is really a huge problem in the care issue.
A lot of
Someone's
assumptions
asking,
and a lot of just lack of education and bias, or they assume the person's going to have complications, they're going to need these medications, and you're not going to be able to breastfeed. But they assume that, oh, she has larger breasts, she's probably not going to feel comfortable, she's not going to find the right position, she's not going to breastfeed. So there are a lot of assumptions that are being made, like right off the bat at the first visit, and that conversation may not even happen, or there's not enough support groups with women that look like them in the support group, or they've seen that. So yeah, lack of support, lack of education, and just lack of
And an assumption that fat people don't care about their health is a
Yeah.
huge assumption. So there's an assumption of, well, why would they breastfeed? They don't care. They're probably eating Big Macs 3 times a day. It's an assumption of lifestyle. It's an assumption that they're stupid. So people see a fat person, they think this person is low class, they are stupid, they are uneducated, they are slovenly, and they don't care about their health. All those things go through someone's head before they even realize they're thinking it. And immediately they go, well, let's just give this person formula, make sure this baby gets fed, because no way are they going to breastfeed if they're stupid and uneducated.
All right, wait, hang on. All right, someone says, this is new information to me. Is there a connection to metabolic issues being the cause of fatness? Like, can we tie it to genetics and, causing fat families, entire families to be fat? I don't know the answer to this. Maybe one of you does.
I mean,
Metabolic issues and genetic.
metabolic issues can be genetic. Yeah, for sure. Endocrine issues can be genetic. I am the smallest person in my family, and I actually get criticized. They're like, "What is wrong with you? Why are you so tiny?" But yeah, that can come about, and then that can snowball of all the information that they receive. Like, oh, we can't breastfeed. Remember, we can't breastfeed because this is just how we're made. So then we get those things that are passed down from generation to generation, and then the doctors start believing it too. Like, oh, your whole family, no one can breastfeed, not even understanding where that came from, the lies that they've been fed all these years. So yeah, of course, it can be genetic.
Yeah, and
Sure.
remember, it can also be epigenetic in that if somebody has had 400 years or 1,000 years of oppression and weathering and, generation after generation of stress, that can cause metabolic syndrome in a family. That can cause metabolic syndrome in a whole population. And then people start thinking, well, those people tend to be fat and those people also tend to not breastfeed. Well, maybe it's because there is metabolic syndrome in that family, or in that, we see higher rates in different ethnic groups and people assume it's somehow genetic. Well, it's not really genetic, it's weathering over generations. We know that.
Yes. Hold on one second. All right. Next question. Whew. They're coming in fast and furious here. All right. Next person wants to know, do you think that we're too quick to label moms who are overweight and or GDM as delayed lactogenesis if milk comes in at 5 days, or later in the still within the normal course of things if their milk comes in later? Are we too quick to blame it on the fact that they are overweight? I hope I interpreted that question well. Yeah.
Yeah, but I don't think that really matters. Like, I guess I'm saying is, I in an ideal world, every lactation case would be looked at individually. And so we're seeing somebody whose milk isn't in on day 5. Well, we're looking at what their individual risk factors are. Yeah, they might be fat, but they might also have had a C-section because of that fatness, that 71% of fat people who got sectioned. They might have had, 27 bags of IV fluids and are, look like the Goodyear blimp at that moment, regardless of how fat they are. They could be abused and stressed. I mean, there's a million reasons, right? And it's all it all together. So yes, of course, I think it's often blamed on the fat, and that's where that research comes in. But it you can have I mean, there's fat Olympic athletes, right? There are people who are incredibly healthy and just happen to have a lot of adipose tissue. And then there are people just like what Nikki was talking about, who are thin, they've been thin their whole lives and are a metabolic mess. So
Yeah. Hank, let's put a pin here for a second, because you just talked about a couple of different terms. And someone said the word obesity is listed in so many lactation textbooks and studies. What advice do you give aspiring and current lactation professionals, presumably around language, around using obesity or fatness? And what do you normally counsel around what words to use?
So, I mean, here we need to just take a second and talk about the fat liberation movement, because it does matter. So we hear a lot these days about body positivity. Ooh, the body positivity movement. Well, the thing is, if you look at that body positivity stuff, we're still looking at people who are largely white, able-bodied, very attractive, and really sort of thin to medium-sized fat, like a small fat, right? Like, oh, I'm a size 16, I love my body, and also body positivity posits that any problem a fat person is having can be solved by love your curves, love your body. It's all individual. So fat liberation looks to turn that on its head and say this is a structural problem. we have some structural oppression going on here. This is, you know, not only do we want to love our bodies, but like we also want to center Black bodies, fat bodies, disabled bodies, trans bodies. And we disconnect health from morality. Because, you know, something, we talk a lot about health and about how fatness can be healthy. But you know something? Some people are never going to be healthy. Some people are never going to be healthy. They are unhealthy, and that's just the way it is. They still deserve to be treated well. They still deserve to not be oppressed in society by their healthcare providers. So fat liberation really looks to change that up, and it goes along with any other sort of liberatory movement. So that's the movement where using the term fat comes from. That obesity is a medical term. It's like homosexual. Like we don't go around calling gay people or queer people, you are a homosexual. Like that's a very medical term. And so, you know, we've learned to say, if we just start destigmatizing the term fat, so many of us have heard it in so many hurtful ways. And it is a reclaiming, but it's not really a slur. It's just a descriptor. It's just a neutral descriptor. Like fat doesn't have to have any more emotional impact than tall, right? But it does, because we have, you know, so many of us have been hurt with that word, but it doesn't have to. And so I call myself fat. I use the term fat, and I use it in a very neutral way, just like I would describe someone as being short or tall, or, you know, have a brunette or a blonde. Does that make sense?
It does. I wonder if, for me, this feels a lot like kind of any other factor about a person's, about their personhood, where I would say, what do you want me to use? What language do you want me to, you know, what do you call yourself? You know, we kind of go in that direction. And that feels more right to me in the way that I approach the work. But I wanted to make sure we address that so folks have the
When you're
opportunity to
talking
go.
with an individual client, we always ask everything, just like we do with everything else. You know, you're not going to make an assumption. But when I'm talking about it with providers, I use the word fat, like fatty, fat, fat, fat. I say it a million times because it helps to really, you know, throw it in their faces a little bit and desensitize them a little bit.
Yeah.
But with a parent, I often say, like, tell me about, you know, if it's important, I say, tell me about your weight history, tell me about, you know, what's going on with your body size over time. And you can just use terms like body size, you know, body shape, tell me about your shape, tell me about how things have been with that in your life. And it is, let me be clear, it is okay as a provider to ask questions about body size and shape when it's relevant. It's just not something that needs to be brought up when it's not relevant. You know, for instance, if I'm assessing someone for insulin resistance, I'm looking at a fat person, I'm likely to say, have you been heavy your whole life? What age did that start at? You know? And that's a reasonable question. But if I'm talking to somebody about, you know, their baby's tongue tie, I don't need to ask that question. I don't need to say to them, so how long you've been fat for? It's not necessarily relevant in that conversation.
Okay, that's fair. Thank you. All right. So, FYI, LER has a great handout on large breasts and getting baby attached, positioning, and all that. While we're on that point, what are your favorite positions for our
So
families? Yeah,
my favorite position one thing to remember, this, not all fat people have large breasts.
true,
In
true.
fact, like a lot of fat people don't have large breasts. Like I'm sitting here with my B cups feeling a little sad about that. And it's actually a sad thing when trying to find clothes too, because clothes manufacturers assume that we all have, you know, big ones, and we do not. But for really large breasts, like super large breasts, my favorite position with a tiny little baby is using the kitchen table. I like to have you sit at the chair at the kitchen table, you plop that boob right on the table, and you stick the baby at the end of it. And you can put a little rolled up blanket or a pillow behind the baby to help them stay on their side. But that is my go-to with someone who does have really large breasts, whether they're fat or not.
Yeah,
And a tiny baby. When the baby gets older, they can help themselves and it gets so much easier. But with a newborn, sometimes that kitchen table position just works.
that's a good one. Nikki, what do you think? What's your favorite?
I like the football hold in
Yeah.
a similar way. I didn't never thought about the table, but just like creating like that type of situation in the bed, where you have a harder surface. So I actually like there's a boppy called My Breast Friend, which is
Mm-hmm.
extremely firm.
Mm-hmm.
And I really like that one because of how firm it is. I actually use mine as a lap desk now, now that I'm not breastfeeding anymore, but having that there, and and just of affirmations. Like at the end of the day, with anybody, I said, whatever position works best for you. So you could do cross cradle, you could do all of that jam, if that's what works best. So I actually show all of them, like, we could do it like this, we could do it like this, with modifications for the larger breast. And I was like, well, how did that feel? How did those feel? And like, oh, I actually like that one. I think the baby was more comfortable, I was more comfortable, and that's how we go. It's kind of like a multiple choice, and they pick which one.
Yeah, for sure. Someone says the ironing board works well.
Yeah.
Never tried that one.
Sidelining in bed works great for large breasts.
That's my favorite. That's my favorite. Yeah, but you gotta have enough breast tissue to lean over there, right? So
well, if you can get that top boob, listen,
you're
golden. I always feel jealous of the large-breasted women who can do top boob at the same time. I can only ever do bottom one. I had to roll over in the middle of the night. Yeah. So just, with fat bodies,
that's me right now.
Love if practitioners, especially practitioners who don't have fat bodies of their own, got used to physically handling fat bodies in a way that didn't, I mean, it's just like, Nikki, when we saw your webinar on dealing with skin conditions with dark skin, that's something that if you don't have that experience, you just don't know, right? And if you don't know, you can't help the person who's in front of you. And so it just takes practice. And I mean, that would be a fun thing to do one time, is to actually get some nice fat bodies and show us how to, don't be afraid to touch somebody. Like there's that repulsion factor. People need to get over that, because doctors tend not to physically put their hands on fat patients because they're disgusted, and it leads to higher, they don't get diagnosed with cancer soon enough because no one will do a breast exam. They don't get diagnosed with pelvic cancers because people don't want to do a pelvic on them. So fat people die at higher rates from preventable illness because no one wants to put their hands on them. I've been in whole doctor's appointments where literally the doctor talked to me from 6 feet away and didn't touch my body at any point, even when it was indicated, because they just didn't want to come near me. And
we have a comment here from an L&D nurse who says, we nurses moan when we see a patient over a certain BMI because it is hard to monitor the fetal heart rate because of larger bellies. I'm acknowledging this bias that we have. I appreciate you being transparent in that. Do better. Do better.
Yeah. And that whole moaning thing, that going back to your colleagues and saying, oh, we've got a fat one in there, it causes so much damage. It causes so much harm. And because please remember that, again, this is intersectional, and you're sitting there and taking, that fat person may also have 3 other axes of oppression. And when you are afraid to put your hands on them and work with their bodies in a respectful way, they may die. They may die. Like, childbirth is a terrifying time, and a lot can go wrong, as we know. And the more oppressed somebody is, the more likely it is to go wrong. Fat women have a huge, and it's interesting, of course, it's intersectional, but fat women with no other axis of oppression still have a hugely higher risk of dying in that first year after childbirth for some of the same reasons that Black women have. It's because they're having provider bias and lack of care, because no one wants to touch them.
Whew, this is heavy.
Don't kill them your patients, right? Don't kill them your patients because you don't like them.
Yeah. And I'll be honest, obviously I'm a Black woman and I deal with several axes of oppression. I love that term. Thank you. I'll be using that now. And it's uncomfortable for me. It's uncomfortable for me to hear other axes compared at the same level. You see what I'm saying? Like, I think there were several times throughout the conversation, Kristin, where you kind of likened it to race, the fat bias to racism. That's a new paradigm. And an uncomfortable one indeed. And I have to kind of process some of this and see where I land on it. But I recognize and understand for sure the bias that you described, and it's real, and it is impacting families, and it is not okay. And I'm so glad that you came to talk to us about it.
It's interesting. It impacts in the justice system. Fat people get longer prison sentences than thin people do. They're more likely to be convicted. And fat sexual assault victims are not considered credible. They're often told they should be grateful.
You can see all that. Yeah.
Workplace discrimination. 85% of hiring managers say they don't hire fat people.
Yeah.
So, Nikki, what are you saying?
I was just gonna say, I understand. I understand where she's coming from, and Nikisha, it does also. It is, it's just a kind of unsettling to hear the comparison between racism and fat bias.
And let me be super clear. I'm not equating them, and I'm not putting one above each other in any way, shape, or form. I'm just talking about like if there's different axes of oppression, right? Like
Right.
there's race, there's sex, there's sexual orientation, there's able-bodiedness, there's all those different things, and they come together in different ways in each individual person, right?
Right. Correct.
This is just another one of those axes.
Yeah.
And it's not more, it's not less. I'm not making a judgment on that. I'm just saying it's another one. And it's one
Yeah.
that people don't necessarily think about. And so, and of course, just like all the rest of them, like if let's say you're a Black woman in a wheelchair, you're going to be having a different life experience than a white woman in a wheelchair, right?
For sure.
Because you also have
So
racism on
they
top of wheelchair.
compound each
Yeah.
other.
Yeah. Yeah. Yeah.
And so this is just another axis of oppression. It's not an equation or saying that they're the same. You know, I mean, if I honestly had to guess, I would say that a fat white woman probably has a much easier life than a thin Black woman overall. But that's not really the point. The point is that it's just another axis of oppression. And my concern is actually for the people who have the most intersections, right?
Yeah.
The person
Yeah.
who's dealing with one after another, after another, after another. That's the person I'm most concerned about.
Gotcha.
Yeah. I wanted to real quickly, because we're running out of time, this has been such fascinating discussion, say that you know, in preparing for this, Nikki and I both read an article about understanding why women with obesity don't breastfeed. Was the title. You know, it's a little bit clickbaitish, but it's based on studies that would say that this doesn't have to do with their ability. It has everything to do with their one belief that they can, based on messaging that they've received throughout pregnancy, right? And lack of support. So there's less initiation and less duration based, a lot of it based in lack of support. So that's why this discussion is so important today, because as the supporters, as the folks working in the fields that can directly impact this, we can make a change today. We can make a decision to say, no matter what size this client is, I'm going to give them the very same level of care. I will make no assumption about their ability to do this unless medically I have come to a conclusion, right, that indicates that they're unable to. Based on, you know, something going on that's not necessarily obvious to the eye immediately. So there's that. The other piece, we can't let you go, Kristin. You've talked about kind of the healthy at any size, you know, love my body how it is movement, how that's not necessarily the same as fat liberation. Where can folks access resources on fat liberation then? On, you know, looking at this through the right lens, what resources do you recommend?
Oh, well, I mean, I can get a list for everyone at a later point. There's a ton of great books. There's, you know, YouTubers that have great podcasts about this and great videos about it. And there's books that are like coming out regularly. One person I can talk about right now is Roxane Gay, is a wonderful speaker. She is a Black woman who talks about the intersection of race and obesity and fatness in her life. And she has a beautiful book. It's called Hunger, that talks about her personal journey and how that intersects with the movement. So I could recommend that right off the top of my head.
Check it
There's
out.
another one called Your Fat Friend, and I'm blanking on the author right now, but that's another great one to start with. But there's a ton of really cool information out there. And if
We're
you
going to
just
hold you to it. We're looking for your resource list. We need it.
I'll give you a resource list. Absolutely.
Nice.
Yeah. And so I just like really hope that everyone just starts thinking about this. Like, I just want everyone to sort of start thinking about either recognizing your thin privilege in life. You know, I mean, can you walk in? Are you sure that when you walk into a store, there's going to be can you get through the aisles? Is there going to be a seat that's going to fit you? You know, is your health not going to be determined by the way your healthcare provider sees your body size? So there's a lot of thin privilege, right? And for those of us who are fat, recognize your own internalized fat phobia. And that's hard. I bet you a lot of people are having a hard time with that right now. I know I certainly did. When I first heard the statistics about like dieting, like, did you know that you have a higher chance of recovering from stage 4 breast cancer than you do from maintaining weight loss for more than 5 years? Yeah, like that's the statistic.
Wow.
Yep. So like when I really digested all of that and actually started believing it, it was a huge amount of internalized fat phobia. And so this is one of those situations where, you know, just like any other oppressed group, fat people believe the lies about themselves. And so we need to sort of detrain our minds from that. We need to liberate ourselves, as well as, you know, with our allies who are thin. So it's a lot. And remember, I'm not saying that people shouldn't try to get healthier if they feel like they are unhealthy. but that's not necessarily about weight. I'm a huge fan of improving your metabolic health. I have insulin resistance like crazy, and Nikki and I have talked about that several times.
Yeah,
We're both big fans of fasting.
we are.
I use fasting as a tool to improve my metabolic health. And if weight changes, it changes, but I'm not doing it for that reason. I'm doing it because I would like to live longer and have less metabolic disease. So I'm not saying that if you're sitting here with, metabolic disease, you shouldn't try to improve your metabolic status.
Yeah.
But that doesn't have anything to do with our weight. And we need to decouple those two things. And
I think that's a great point. I really appreciate you bringing that up. I can share, my mom, I get really frustrated when my mom goes to the doctor because she says, oh, they said this number was a little elevated and this was a little elevated. And I said, what do they say you can do to change those numbers? Oh, lose weight. How do they tell you can lose weight? They didn't say. They didn't say. What?
and the reality is that
Because mom, you walk 5 miles, power walk 5 miles a day and drink nothing but water. And you're like, what more are they telling you need to do to lose weight, mom? They didn't say, they just said lose weight. And so she has the same lecture again next time and the next time. Yeah.
And it's because they don't know.
Yeah.
It's because they don't understand what those of us who have done that research, that's a whole nother talk about improving metabolic health through ways that seem scary to a lot of medical people. But I'm right at the end of a 36 right now, so we can talk about that another time. But so the 2 points, if I can make any points, it would be decouple fatness from health, because they're actually not causation, it's correlation. Okay, so decouple those two things. But the other point is that decouple health from morality, because some people are not healthy either now or ever, right? I may always have insulin resistance. I may always have a bad metabolic profile, but it doesn't mean I'm a bad person that's deserving of poor care. So, my fatness is not necessarily caused by, correlated to my unhealthiness, and my unhealthiness is not at all correlated to my goodness or worth as a human being.
I get that. Thank you.
Those are my big
Thank you for
points.
that. That's huge. We've got tons more questions. I'm asking Angela to capture their contact info so that maybe you can email back and forth with them, or they can, write into LER with their questions, and we will all get a chance to get back with you. But Nikki's got to run and check on a patient. We want to make sure that we're respectful of her time today. It's something.
Yeah, and I want to let everyone know they can also just hit me up on Facebook Messenger. That's fine as well.
Fantastic,
Well,
Kristin Cavuto. You will find her on there.
Thank you so much for your time today.
Thank
Nikki,
you guys
can you
so much
remind
for
me?
having me.
Thank you for coming. Thank you for sharing all this great information with us. Nikki, can you remind us of our next date? I'm blanking right now.
Our
Do you
next
see it?
date is December the 9th, same time, same place. We're going to wrap up 2020 and do a vision board and just really like, what is your vision for lactation going into 2021? Recap what's all transpired this year, and then go into 2021 with a new vision.
With some intention.
Yeah.
Let's do it. Thank you again, Kristin, for your time. Thank you, audience, for listening. Thank you for all your questions. If you didn't get them through, get them answered, make sure you reach out to us, and we will make sure we get back to you. We appreciate you. Stay safe. Stay sanitized out there, people.
Stay sane.